Welcome to today's webinar, How Much Supply Do I Need? A webinar series on estimating health commodity needs in emergency settings. This is part 2, forecasting of kits for emergency response. As always, we are very glad to have you with us, and a special welcome to anyone who is joining our webinar series for the first time. This is our second webinar for 2021, and this webinar continues the topic of quantification that started in part 1, which covered planning for a quantification exercise and the basics of forecasting. We will provide more information about part 3 of the webinar series at the end of this webinar. Remember that anyone who attends all 3 webinars in the quantification webinar series, either live or on demand, will receive a certificate. As a reminder, this webinar is being recorded, and we will share the recording with whoever has registered or logged on, and we will share additional resources as well. My name is Barbara Lamphere, and I'm joined by my colleague, Laila Akhlaghi, to present this webinar. Laila, please introduce yourself to our audience.
Good morning, good afternoon, good evening. My name is Laila Akhlaghi. I'm a Senior Technical Advisor at JSI with about 20 years of providing pharmaceutical system strengthening technical advising across Africa and Asia, mostly focusing on forecasting and supply planning. I'm a pharmacist with graduate work in public administration and supply chain management.
Thanks, Laila. And I'm Barbara Lamphere. I'm a Senior Technical Advisor at JSI, working in the area of organizational development, performance improvement, and capacity building across a number of technical areas, including reproductive health, immunization, and humanitarian response. And I've worked for the past 30 years in many areas across Africa, Asia, and the Middle East. Again, we are happy to have you with us. As we get started, we invite you to use the chat function in Zoom to introduce yourselves to others who are participating in the webinar. You also may share some of your experience using the chat function throughout the webinar. So if you have any experiences you want to share with your colleagues, feel free to do that in the chat. As always, we will take questions at the end of the presentation. If you have a question anytime during the webinar, please use the Q&A button found at the bottom of your screen to submit your question. Please do not use the chat button for your questions. We have also had requests for the webinar in French. And while we are unable to present in French now, please do feel free to ask questions in French. We can answer them in our follow-up email to this webinar. And in general, if we cannot get to all the questions during the Q&A section, we will respond to those also in our follow-up. So now let's get started.
Thanks, Barbara. Let's start with a quick introduction and overview.
We first want to give you a brief introduction to the USAID Bureau for Humanitarian Assistance, BHA, Capacity Building Program, through which this webinar is made possible and which is being implemented by JSI Research and Training Institute, Incorporated. The overall aim and objectives of the program are shown here.
Here are the objectives for today's quantification webinar part 2, forecasting for kits for emergency response. We'll start with a quick review of quantification, and especially for the forecasting portion from the part 1 webinar. We'll present several kits that can be appropriate for use in emergency or humanitarian situations, and we'll review the contents of some of the kits, as well as some of the advantages of using the kits. We'll look at a suggested methodology for kit forecasting. We'll present some of the challenges that we may face when using kits and ways we might address those challenges. We'll look at a process that we can implement when moving from procurement and management of kits to the procurement and management of the individual items. And finally, we will review the instructions for playing the next round of the game as a follow-on to this webinar.
We do want to mention and recognize UNFPA, WHO, UNICEF, and PATH, Some of the content for this webinar was adapted from resources and information that they make available on the internet. The presentation and interpretations of the information are ours. And if we do happen to misunderstand something, it is our mistake and not theirs. Please feel free to comment on anything related to this using the Q&A function. As always, we will share links and other resources related to the content we will present, and we are recording the webinar and we'll share that as well. Actually, let's start with a quick poll. The topic of our webinar is kits. So let's get a quick indication of the experience of our participants with kits. So I've launched a poll, and the question is, do you have any previous experience using kits in humanitarian or emergency response situations? So feel free to answer this poll. Just going to give it a second or two more. Okay, let me share those results. I'm going to end the polling and share the results. I hope you all can see those results. More than half of you have some experience using kits in humanitarian or emergency response settings. So it'll be interesting to hear about your experiences in the when we have the Q&A section, and feel free to share anything in the chat or in the Q&A that is related to your experience in using kits, and particularly related to quantification or forecasting for kits. So I'm going to stop sharing those results and move on with our webinar. Before we get into the topic of kits, let's do a quick review of what we mean by quantification and related concepts. Remember these basic definitions that we presented for quantification and for forecasting during our last webinar. Some of the important takeaways are that the forecast only refers to the expected future consumption of the products, and that the supply plan that results from the overall quantification process will include the quantities we actually need to procure. Remember that we will cover supply planning, including for individual products and kits, during part 3 of the quantification webinar series. During our last webinar, we presented this diagram of the process for quantification and went into some detail related to preparation and forecasting. We will share the link for the part 1 webinar again after this webinar. We also looked at these 3 steps in the preparation process so that we are ready to conduct our quantification. Aside from the program scope and purpose, we presented and reviewed the different data that we need, both for forecasting and for supply planning. We also looked at these considerations, which are particularly relevant to quantification in the emergency or humanitarian response context.
We looked at the 4 main steps in the forecasting process. We discussed forecasting data, including the historical consumption data, historical services data, demographic and morbidity data, and service capacity data. And we presented some of the potential sources of these data as shown here. We also talked about some strategic ways we can use data when we don't have the exact data that we need, that we would like to have. We mentioned the importance of trying to produce forecasts using as many data sources as possible, and then reconciling the forecast to produce a single final forecast. And again, the final forecast will be the predicted quantities of products to be consumed or used each year of the forecast period, or the demand.
So that was a quick review of what we covered in part 1 webinar. And if you missed that, we will send you the link in our follow-up email to this webinar today. So you will get a review again as needed. So everything we said about forecasting will also apply to the kits that we might be procuring in an emergency situation. But let's turn our attention to kits, which we will see also have some particular aspects relevant to forecasting. We will start by defining what kits are, and then by looking at some examples of kits and their contents. Please keep in mind that our objective for this session is to focus on kits that are commonly used in humanitarian or emergency situations. There are other kinds of kits that are used on a routine basis. For example, USAID packages Depo-Provera along with the syringes needed, and these are shipped in a kit along with a sharps disposal container. Although we are not focusing on kits for routine services during this webinar, some of the concepts that we discuss specific to kits can also be applied to the routine kits. Let's first look at a dictionary entry for kit. And here we see a couple of definitions: a collection of articles usually used for personal use, a set of tools or implements, a set of parts to be assembled or worked up, a packaged collection of related materials. In our context, some of these definitions are perfect as is. Others we would modify slightly to fit our exact context of forecasting for emergency supply kits. So let's see how we might use these definitions. For the first definition, we won't focus on personal use, but rather public health services. For the second definition, we will also keep the idea of a set, but not necessarily tools or implements. Instead, we will focus on health products, which may of course include health implements or equipment. For the third definition, we can keep that one as is. It again focuses on a set, but this time with the added element of to be assembled. For the fourth definition, we can also keep that one as is. The focus is on the packaged collection, and our materials will be related to a health service. As we go forward in the presentation, when we say kit, we will mean kits of health products for use during an emergency or in a humanitarian response setting. Now let's look at some examples of kits and see why we have chosen these definitions as is or with modification.
There are a number of different kinds of kits for emergency or humanitarian situations available from individual organizations such as the WHO, UNFPA, and UNICEF. Plus kits that are developed but not provided by other organizations, and those that are endorsed by Interagency Working Group on Reproductive Health in Crisis, with input on kit contents provided by the Interagency Working Group. Some of the commonly used kits are listed here. The links we share after the webinar will show other kits that are available. All of the kits have in common some of the elements that we discussed a moment ago in the definitions. They are packages or kits of a set of health products intended to provide a type of health service to a population. We will look at a few of these kits in a little more detail. After the webinar, this list and links to information on all of these kits will be included in the information that we share. We also want to mention that kit contents can be regularly updated. So there may be some newer information compared to what we present now, or that will be applicable at the time your country or program might inquire about or procure any of the kits that we discussed here. One of the kits from the previous list is the Interagency Reproductive Health Kit, which can be procured from UNFPA. The guidance for use of these kits has recently been updated and are available as the 6th edition online. And this is the version we're referring to in this webinar. As with some of the other kits, this is actually a set of kits with different modules, each of which is for a specific service. For example, Kit 2, the Clean Delivery Kit, there is a Module A, which has products to treat the client, and Module B that has the products that the service provider needs to do the treatment or provide the service. Kits can also be organized by level of healthcare. In this example, each color represents a different level. The first 5 in orange are for the community level. The next 4 in green are for primary healthcare facilities. And the last 2 in blue are for referral hospitals. Note that the levels of kits are additive. So a primary healthcare facility would also receive any community level kits relevant for the services they provide. And of course, the services offered per level will also depend on the structure of the health system or the humanitarian program. We also want to mention that kits can be divided into core kits and complementary kits. The core kit, such as the list of 12 that we saw a moment ago, provides products for basic services, while the complementary kit provides products for additional services. But the complementary kits are not designed as a standalone kit. The example here shows complementary kits for the community level interagency reproductive health kits and the core kits that they complement. We also note that some kits consist entirely of bulk products. In this context, bulk means individual products and not necessarily large quantities, but enough to complement the kit for the target population numbers. Each kit would then have a set quantity of each product that is included in that kit. The SCI treatment core kit, for example, has 27 items, and here is a partial list of those kit products and quantities. In a moment, we'll look more closely at how they arrived at these quantities per kit. From the information provided related to the kit, in this case, the IARH Kit 6th edition manual, we can also observe that these particular kits are designed to treat certain illnesses or conditions. In this case, the kit for STIs and the conditions are genital ulcers, urethral discharge, and vaginal discharge. Also observe that this kit covers adults and pediatric cases.
This is another type of kit. Generally, a dignity kit includes a basic set of supplies that can be distributed to women and girls to help them manage their menstrual health and hygiene needs. These kits may include other items appropriate to the culture and needs of the target population. The best known is probably the UNFPA Basic Dignity Kit pictured here. The current version of the kit that can be procured from UNFPA contains the items shown here. And here is an example of a different kind of kit. This one is the Clean Delivery Kit, designed by PATH, but not produced or distributed by PATH. Rather, it is the list of recommended products to include in the kit, but with the intention that the individual products that make up the kit will be procured locally and then also assembled locally into kits for distribution. And we can see the recommended list of items here. We also note that in some countries, such as Haiti, they have adapted the contents to local needs. And WHO also has come out with its own recommended list of products for a clean delivery kit. Here are brief descriptions of some of the other kits from the list that we showed earlier. And again, we will share links that will show more kits and more information about the kits after the webinar. So take a few minutes and read about these kits.
Let's now quickly look at a few advantages for using kits. We will highlight some of the challenges of using kits after we discuss forecasting methodologies for kits. We'll also discuss some of the challenges later. There are at least a couple of reasons why we might want to use kits, and some that are particularly relevant for us in a humanitarian or emergency context.
So here we see some of the possible advantages to using the kits. In many cases, kits might be easier to manage or transport. That's because there may be fewer suppliers, fewer stock keeping units, and therefore also fewer orders. There may be fewer individual boxes to handle. So if you have fewer boxes or fewer items, fewer orders or fewer SKUs, kits may be more efficient to manage and transport. And if these things are easier to manage and transport, they're easier can result in faster. Kits may be less expensive to manage and transport, and easier and faster can result in less expensive. Kits may be easier to forecast because it's easy to figure out the number of kits if you know your population size. And in an emergency, easier and faster is better. Among all of these things, we can say that in an emergency, faster would generally be better. Please note that these advantages apply in many cases, but when we discuss challenges, you will see some cases where kits may not be easier to manage.
So now let's look at our actual forecasting methodologies for kits. As we get started, remember what we said in the part 1 webinar about forecasting for a new product and how that might be applicable to kits. We likely won't have historical data for kits, even if we have data for some of the items that are part of the kit. Here is the definition of forecasting that we saw previously. Forecasting product consumption is estimating the quantities of products that will be dispensed to clients or used by a health program over a specific period of time in the future. Let's now update that definition so that it refers specifically to kits. Remember that now the product we're referring to is the kit itself and not the individual contents that are found in the kits. So here we'll change out the word products to kits and the health program to a number of facilities, which can be for specific regions of the country or for the country as a whole, if that is the case. We can now keep in mind that the output of our forecast will be a number of kits that we expect to be consumed or used during the forecast period in the facilities found in the area or areas impacted. Most of the steps in the forecasting process don't change, and we will again specify kits for the products being forecasted. We'll still organize, analyze, and adjust our data. We will see in a moment what kind of data we'll be working with. We'll still build forecasting assumptions, and we'll see an example of that later. We will, of course, estimate the consumption for each kit. That's the forecast. And again, we will not be forecasting specific quantities of each product in the kit, but the number of kits themselves. For reconciliation, that's a step in parentheses. We will see why in a moment. So now let's think about how we will apply the forecasting process to the forecasting of our kits. For kits such as the interagency reproductive health kits that we saw earlier, they're designed to serve a set population for a set period of time. As you see here, the kits are designed to serve populations of 10, 30, or 150,000 people for 3 months. Note that this is general, the kit contents cannot be split. So if the population that would be served is less than the number intended for the kit, you will still need to get 1 kit. and the kit would simply last longer than the estimated 3 months. So let's try one example. Forecasting kit 5, treating sexually transmitted infections, with each kit designed for a population of 10,000 for the period of 3 months. Remember that for an emergency, and especially for a first emergency, we'll likely not have any consumption data on a number of kits. So we will have to rely on other data for our forecast. Since the unit of measure for the use of the IARH kits is the general population, we'll use the population data, which includes demographic and morbidity data as the basis of our forecast. So for example, for the STI treatment kits, our first instinct would be to ask, since the kits each serve a population of 10,000, why not just divide our target population by the 10,000 to get the number of kits we need? We see that example calculation here for an expected target population of 400,000. This is for 1 3-month period. So if we then adjust and multiply the number needed for the number of 3-month periods we think the situation will last, we'll get a total number of kits. In this example, our total forecast period is 6 months. So that would be 80 kits. And if we're using this methodology, we would do the same kind of calculation for each kind of kit.
But Laila, doesn't this assume that our target population is evenly divided throughout the country and among the service delivery points?
Yeah, Barbara, that's an excellent point. We do need to account for the fact that our population is not evenly divided through the country and among the service delivery points. These factors would also impact our forecast for a number of kits required. Let's see how this factor would impact our forecast. So here we have some disaggregated data that shows how the population is divided by health facility or catchment area. Using these numbers, and for the same total population of 400,000, we see that the number of kits we actually need is 44 for the 3-month period, compared to what we said earlier, which was 40, and 88 for the 6-month period, compared to our previous 80. This, of course, is due to some rounding up of whole kits that were required for smaller population areas.
Exactly. Remember that we should not be splitting the contents of a kit. For example, we should not have 2 facilities share the contents of 1 kit. Trying to split the contents of kits and distribute like that would cause a nightmare. So our approach would be to do our kit requirements per health facility or per catchment area, and then calculate a total number of kits needed. Our eventual distribution plan would also be related to the forecasted quantities required per facility.
Another consideration we need to take into account is that there are probably some facilities that don't provide some of the services, so they would not receive a particular kit. In this example, the primary healthcare facility X does not have trained service providers to do IUD insertions or vacuum extracted deliveries, so they would not be eligible to get those specific kits, and their facility would not be counted in the forecast for them. You see those bolded zeros. So in addition to disaggregating by facility to know the number of kits per population size, the disaggregation can also account for facilities that do or do not provide a particular service. Keep in mind again that for these kits, the calculations and forecasts are based on total population of the catchment area.
Here is the UNFPA Dignity Kit that we saw earlier. We want to mention now that for this kit, it is basically, the forecast for this kit is basically directly on the number of the women and girls that are intended to receive the kit. For the UNFPA Basic Dignity Kit, it would be likely 1 per woman or girl within a certain age cohort for this kit. So the forecast consumption quantity of kits would be 1 times the number of women and girls. The number of women and girls would still be determined by using demographic factors such as percent of the population that is female, percent of females in a target age group, and then percent of those females that would need a kit. You also might factor in an extra quantity or percent in case some products are lost, stolen, or damaged, and replacement kits are needed. And I want to point out that this kind of extra quantity is for personal use. This is different from a supply system buffer stock quantity. And here again is the example of the clean delivery kit that we mentioned earlier. This kit is distributed based on 1 kit per expected delivery. So you would rely on population data related to the number of deliveries. In this case, you might have some historic service data related to the number of deliveries per health facility. So you could use that data to produce a forecast. You might also have specific data on birth rate in women by age groups. So again, you could use that data. Of course, for this kit, the items would still be purchased and assembled locally and then distributed as kits, not as individual items. Here is a summary of how we will likely be doing our forecasts for kits based on how they are designed. For a population, for a specific target population, or for an expected number of cases or treatments or procedures. And we will likely be limited to using demographic and morbidity data, and perhaps services data if we have it. We would want to have the data disaggregated down to the facility level and by type of kit. So coming back to our forecasting steps, the data that we collect, analyze, and adjust, and the services, and that serves as the basis for our forecast, will depend on how kits are designed and the units that they use, such as the examples we have seen, based on total population, based on a specific target population, based on a number of procedures. We also see why we put reconcile forecast in parentheses. Most often for these kits, we will only have demographic or morbidity data available, though we did see at least one example where we might have some other data. In many cases, we would not have different forecasts to reconcile. But as we also said during the part 1 webinar, if we are working with only one forecast based on one type of data, we can still use the reconciling step to review our forecast assumptions and make sure they are as accurate as possible. Before we move on to our next subtopic for the webinar, we do want to let you know of a couple of example tools that are available for forecasting of kits. We don't have time to review these tools now during the webinar, but we will share the links with you after the webinar so you can explore the tools on your own. Please note that for the cholera kit calculation tool, the link takes you to a 1-hour self-paced training session through which you will learn about the tool and then you can access the tool. The other 2 links that will take you to pages that have downloadable links for those specific tools. We earlier saw a few advantages to using kits. For example, with a fewer stock keeping units, they can be easier to manage, and with fewer cartons to manage, the transport might be easier. However, there are also a number of factors that can result in challenges and that we need to take into account these challenges when using kits. Let's look at some of those factors and challenges now.
One of the first things we have to keep in mind is that the contents of each kit are based on a certain number of assumptions. Here is an example we saw earlier for the STI treatment kit for IARH, kit number 5. We can see that there are no fewer than 8 assumptions made related to STI treatments, including the number of patients afflicted by each condition, And if we apply standard treatment guidelines, which also involve assumptions in terms of the products used to treat each condition, then we can estimate the total quantity of products needed to treat the STI condition, as we saw in part 1 of the webinar when working with morbidity data. The challenge here is that your population profile may or may not reflect the profile covered by the assumptions that were made when developing the kit and determining the quantities of products. Perhaps your population has different rates of adult infection, or the distribution of specific conditions is different. In each case, the quantity of each individual product may vary from what is in the kit. Also in this example, they account for only 3 medical conditions. If there are other STIs that are common in your situation or that you want or expect to also treat, then other products would be needed in addition to those found in the kit. In this situation, you would either need to find a different kit that has the products needed to treat the other conditions, or you would need to purchase individual bulk items that are needed to treat those conditions to complement, and then distribute them along with the kits. Here are some example assumptions that the creators of the kit used to come up with the quantities needed for newborn kits, which can be distributed to women either at the time they will deliver or during the 3rd trimester. Again, the challenge is that if the characteristics of your target population are not identical to those that were used when determining the makeup of the kits, then you would likely have some products that will end up in oversupply or that will be in short supply, and so on. For instance, if the crude birth rate in your country is greater than 40, there will be more deliveries and more women in 3rd trimester, but one kit would still only serve 100 women. So in this situation as well, you may have to procure additional newborn kits or perhaps procure additional quantities of some of the individual items and provide those with the kits. For this example, you might have service data on a number of deliveries or the number of live births or something similar, but not sure where to best put this. Okay, excellent. Another challenge is the distribution of the population. We saw this one earlier, but we mention it again here as a challenge to emphasize that we would really need facility-specific population data, the number of people in the catchment area or the area that the health facility serves. This data might be difficult to find, so we will need to go back to some of the techniques that we mentioned for adjusting for missing data in the part 1 webinar, such as extrapolation. We might also be able to use data from some Sentinel sites for which we have good data from to try to estimate the data for other facilities. Another challenge, and this was brought up in one of the questions and answers earlier, is that the kit might have different products with different shelf lives. As we see here for these indicative shelf lives of products for the STI treatment kit, the shelf lives for just 3 of the products shown here vary quite a bit, from 2 years to 4 years. The shelf life of the kits is, as a whole, would correspond to the shelf life of the item in the kit that has the shortest shelf life. Of course, individual items will still be useful for the duration of their own shelf life, just as they would not have the entire treatment protocol if one product expires. So you might be short some of the products that are needed to provide the service intended by the kit. Of course, in an emergency situation, the kit contents might be moving very fast. They're meant to last, in this example, 3 months, for example. So shelf life may not be an issue, but it's something that we would need to be aware of. But in any case, you might end up needing to procure some of the individual products that have shorter shelf lives if the other longer shelf life products are not used up around the same time period. Another challenge with any kit, either for emergency or routine use, is that there will likely be some products that will get used faster and some slower. So there will be shortages or overstock, and the overstocks potentially leading to wastage. This would especially be true if there was any kind of leakage from the kit, where products were borrowed from the kit to alleviate a shortage of the same product, which is managed as an individual product for routine services. In other words, for non-emergency programs. We also noted this before in our discussion of forecasting, but want to mention it again here as a challenge. For each type of kit that will be used, you likely need to forecast at least one kit per facility that provides a service, even if the facility does not serve a target population as the size planned for in the kit, such as the kits for a population of 150,000 that we referred to earlier for referral hospitals. It may also be necessary in some cases to split up these contents of the kit and send only a portion, so that there would not be one kit to one facility proportion. But please keep in mind, however, that when splitting kits, it's not recommended and would also involve additional challenges. Some of the kits are very voluminous, and this can cause challenges in itself. While one package might be easier to handle and transport, as mentioned in the advantages, if the package is too large, then special handling equipment might be needed, such as a forklift to move a pallet. Also, the large pack size of the kit might be difficult to manage or store in a very small facility. A final challenge that we want to mention is the possible desire to keep kits in our supply chain as a normal way to manage products contained in the kits. We've seen this before, and we saw that there are some advantages to using kits, so that might lead us to try to use kits routinely. But there are many dangers in doing so, some of which were reflected in the other challenges that we just spoke of. We also have to remember that many of the products in the kits have multiple uses, so even the forecast numbers would be faulty if we only procured kits, which, as we saw, are designed to treat or manage only a portion of health conditions. Also, kits often don't have the exact treatments appropriate for the local population. It's not advisable to use certain antibiotics or medicines long-term if, for example, in that country, there's resistance to that treatment. It would be better to update the standard treatment guidelines and the essential medicines list, and then buy the individual products that are best suited for that population. In fact, in the documents that support kit procurement, kit producers typically emphasize that these kits are not intended or designed for regular routine resupplies. And again, this would be for many of the reasons we've just been discussing in terms of disadvantages of kits.
We have mentioned several times that kits are not designed to be used, nor should they be used for regular commodity management or regular resupply. So now we want to spend a short time to discuss some tips on how to manage a transition from the use of and forecasting for kits to the use of and forecasting for individual items. It is extremely important to plan for and move to procurement of individual items as soon as possible after the acute crisis. As well, it is important to move from tracking the consumption of kits to tracking the consumption of individual items. Procurement and distribution of individual products based on demand estimated from actual consumption will result in cost savings, less wastage, and better health services. Yes, let's think about what we might have to consider when the acute emergency or humanitarian crisis has passed and we've entered the protracted phase or post-crisis phase. Here are a list of a couple of considerations. What do we do with the remaining kit products? How do we change our forecast methodology? What data might we have available for forecasting now that we didn't have before? What other supply chain considerations may be impacted by converting from kits to the use of individual items? One of the first decisions we will have to make is which products from the kits will remain in our health system. Remember that when forecasting for kits, generic assumptions are used and will never be accurate for every setting. There will ultimately be products within a kit that are used at different rates, and some will last longer than others if used at all. If any of the kit products are already in our system, but used to treat other routine health conditions, then the decision is a bit easier. We keep those products in the system and integrate them into our routine stocks. For any products that are not already in our system, in other words, which came into the country or the program or the area for the first time as part of a kit, we have to decide if the product will be needed in the future based on the expected disease patterns. If the health condition will continue to exist, then the products can be integrated into the routine supply chain. If not, then a decision will have to be made as to what to do with those leftover products. A few of our choices might be to destroy the products, in which case we need to have a system in place for doing that. Or perhaps we can sell or donate the products to another country that can use the product. If so, then we have to have a system in place for doing that as well. Also, if we decide to keep some of the products from the kits in the system, then we need to be able to forecast what their demand would be in the future. Ideally, we want to try to access logistics data related to the products used during the event, and then that will remain in our system. But remember that our forecast data originally resulted in a number of kits, but now we need logistics data on the individual products. For this, facilities can calculate and report their estimated average monthly consumption for each of the kit contents based on the total quantity received, whether a number of kits received or a number of products, what quantities from these kits they received, the number of months used, and the quantity remaining as shown here in the table. Then using the max min stock levels set by the system designers, either for the products generally or specific to the new individual products coming from the kits, the facility can calculate their next resupply quantities needed, as also shown in the table. Then after that, the facilities would continue to manage the products normally. At central level, they can use the facility average monthly consumptions and stock on hand for national level forecasting and supply planning. If a product was used both specifically to respond to an emergency and to provide routine services, then there would have to be some further analysis to determine what portion of routine consumption will remain and how the emergency-related consumption will impact that. For example, will a health condition end up with a higher morbidity than before, or will it return to its lower pre-emergency levels? Also note that the average monthly consumption for the individual products in the kits can be different. If, for example, you had some used outside of kits and some that did not last as long and other situations.
We can also consider that we would like or likely will be gathering new data from the areas impacted by the emergency or humanitarian situation. For example, we might have new demographic data or morbidity data that shows new trends. Morbidity patterns or behaviors may continue to change through the emergency and crisis. For example, due to loss of family members, there may be more of a desire to expand families or have more children, rather than past patterns of contraceptive use. Some trauma conditions are likely to decrease and some chronic conditions to increase. In any case, we need to continue to monitor the demographic and morbidity data and routinely update a morbidity or demographic database forecast to help get to a more accurate, reconciled forecast. Finally, we have to consider that the transition from kits to individual items can impact other elements of the supply chain. For example, we'll now need to store products differently. They will need to be stored now as individual items, likely on shelves, and not just pallets of cartons containing kits. This can also require more manpower to manage the products. Another consideration is that any new product that comes into our system will need to be tracked in the logistics management information system. So any paper-based or electronic tool will have to be updated to include these new products. There are probably other supply chain elements that can be impacted, but these are just a few of them.
That brings us to the end of the technical content of part 2 of the quantification webinar. As we did after part 1, we will continue with the game that we started. So let's review some information and instructions about gaming. The game and your participation in it are intended to enable continued learning and to reinforce some of the messages and information that we have discussed during the webinar. So what will you need to play the game? Well, you'll need a computer or a mobile phone with a stable internet connection. You'll need a web browser. Any web browser will do except for Opera. And if you have Opera, apologies, you'll have to find an alternate browser to use. And you need your enthusiasm and desire to learn to play this game. We will share these instructions with you in the follow-up email, but this is the web link to get into the game. If you've already registered for the game previously, then you don't need to do that again. You can just use your username and password that you had created before. If you have not registered, you use this code and create an account, and that was the same username and password you'll use for subsequent logins. And then you'll scroll down to the game that's called Estimating Health Commodity Needs in Emergency Settings and hit the play button. And it should look something like this. And here's a few tips on playing the game. The questions in the game are multiple choice. You can choose the question and then it'll move you on to the next one, assigning a score to your account. To maximize your score, you can use the jackpot feature, which is a button in the upper right-hand corner of the game. You click on that button and you can earn extra points. You can actually double your points. If you get the wrong answer, however, you could lose all your points. So think wisely about using the jackpot button. And if you are on the game with playing against another player at the same time, and you both hit the jackpot and you both get the correct answer, the first person that gets the jackpot will get the points and may actually steal some of your current points. So it adds to the competition and excitement of the game. So happy gaming. We hope you will use that to review the content of this webinar. This is the end of part 2 webinar on quantification. Today, we have reviewed the basic principles of quantification and forecasting, described a variety of kits that can be used in emergency and humanitarian response situation, described some advantages in using kits and a methodology for forecasting the kits. And we've described some of the challenges in using kits and how to address those challenges. We've also reviewed a process involved in transitioning from the use of kits to the use of individually forecasted items. And we've shared the gaming instructions with you. We do have some time to answer a few questions that have come in, so let's do that now. And as a reminder, if we don't get to all the questions, we will respond to those in the follow-up. So when I look at the questions, let's see. I have a question here that says, and feel free, anybody can answer, Laila or those of our other panelists can help answer these questions. How to put multi-factors into consideration when the forecast purpose is to cover different health facilities need, then that distribute different types of kits that serve different catchment population areas. So I think this is about the complexity that we have. Different health facility needs, different kinds of kits, and different catchment area population sizes and so forth. Laila, do you want to try to answer that question?
I think what might be the difficult part would be if you have duplication of products to cover the same disease state in the different kinds of kits that you're ordering from, but that would be something that you would need to review. I'm not sure if I understand completely what the questionnaire is trying to ask, but that's just a challenge with this kind of work, and it's part of the process.
Yeah, it is very complex, and you'll find yourself doing many different kinds of calculations to and having to get into some very very minute detail when doing your quantification for kids. There's another question. There seem to be condom and IUD kits. Are there kits for other contraceptive methods like implants, injectables, and permanent methods?
Yes. Yeah. The IARH kits have those products, and I believe some of them are complementary, so you can order them as needed. And as one of the gentlemen has responded, that is kit number 4.
Okay, great, thank you. I think that we've had some questions that have been answered, and I'll ask any of our panelists to share any of the questions that that seem to be.
And we do have a raised hand.
Okay.
Should we
Yeah.
open that up?
Can you do that?
Sure. Theodore? You have been unmuted if you want to ask a question.
Okay.
Okay, I'll mute you back, and you can type in your question if you want. I see another raised hand for Emmanuel Dacombe.
Feel free to share your question out loud if you've been unmuted. Do you?
Okay, I'm trying to unmute you. It doesn't seem to be working.
Okay.
In the meantime, this is Nadia Olsen. A pleasure to be here with everyone. I'm one of the panelists to help answer one of the questions that was asked in the Q&A. There were a few questions about HIV prevention and treatment products, if they're available in kits. Some prevention products are available in kits, but not treatment, because it's not very wise in many cases to introduce new treatments to countries that have existing protocols for ARVs. It's similar to antibiotics. If there's issues with resistance, then you wouldn't want to introduce the wrong treatment to a country. So for this reason, it's more advisable to continue your patients on treatment in the country to the best of your ability with the existing product you have in country, or the treatments that are specific to that country's standard treatment guidelines.
Thank you, Nadia. Yeah, I want to recognize that we have Nadia joining us, and Greg Roche is also helping out with the panel today as well. There was a question about where can we get information of shelf life expiry information on some items, such as disposable face masks that are not described on packaging. And I don't know if anybody would like to answer that question about where do we get the shelf life and expiry information on some, this is related to PPE, I think mostly. If it's not on the packaging itself.
I think that perhaps one of the options would be to contact the procurer directly, and they would be able to find that information for you.
Yes, that's usually that, the procurer or the distributor, or even the manufacturer. And if you are having specific questions, we can also try to help investigate some of those for you as well. Were there any other, I see the panelists have answered several questions. Were there any other questions of interest that we want to share from the panel? Any other ones?
No, there was a question. Sorry, go ahead, Chris.
Yeah, there was a question about multi-factors in consideration when you're looking at different facilities that use different types of kits.
Yeah.
So I would just refer back to the content that you mentioned during the webinar, is that you really want to try to start with a facility level forecast. And so you'll disaggregate your facilities by which services they offer, and their catchment areas, and then build your forecast up from that. So you could have, for example, in a, let's say, one catchment area, you've got 3 reproductive health clinics and 1 HIV clinic, then you would forecast for the 3 reproductive health clinics those kits that they need to provide their services, and then the 1 HIV clinic that has obviously the whole catchment area, so they're going to cover a larger population. But I think basically, essentially, it's building from the ground up, starting at the facility level.
Thanks, Greg. Thanks. I'm going to stop now. We're at the top of our hour.
Hello.
Oh, yes. Hello.
Yeah, can you hear me?
Yes.
Yes, we can. Please.
Okay, thank you very much.
Did you have a question?
Thank you very much for this webinar. It's very useful. I wanted just to do a comment and share my experience, more than 10 years managing interagency reproductive health kit, emergency health kit. As you said, usually you have to get kit per health facility. But this work when you are in camp, refugee or IDP camps, when you have many catchment area, as you said, figures may change. Then we have, for example, the kit 1, condoms, kit 2A, and kit 3, post-rape kit. Well, if you have, for example, many health facilities who are receiving not a lot of cases, then you can split those 3 kits then to respond to their needs. Because sometimes if you put 1 post-rape kit, we take about 15 3 cases per month. This is enough.
Okay.
To meet. Thank you very much.
Thank you for your contribution. Any responses or comments from the panel on splitting the kits? I know that.
Yes, this is Nadia. Just to say that, yes, I think the point that the commenter is making is that when you begin to know what the demand is better in the situation, and it's not a refugee camp, then sometimes whatever you've estimated for the camp situation or facility based is not the best way to quantify. If you have better information, you can override that. But then in that case, you have to break down the kits, especially if it's way more than what you need. So you have to break it down of some products and less of what you need of others.
Right. Yeah. So essentially you're moving towards management by and forecasting by and distribution based on individual items, and hopefully using some demand data to help drive those decisions. Great. Thank you.
That's right.
Thank you for the questions and contributions. And I think the bottom line is you use the data that you have and you update as frequently as you can with the best data that you have available to you. I'm going to stop the question and answer now. We've come to the top of our hour here, and I would like to remind you that we will be any remaining questions we will address in the follow-up email after this webinar.
We also want to mention to you that this webinar was recorded, and we'll be sharing the link to the recording in the follow-up email. There's a reminder that the part 3 of the webinar and quantification will be presented on Tuesday, the 20th of April at 1300 GMT. And of course, that webinar will also be recorded in case you cannot attend in person when it is the first presented on April 20th. Remember that you'll receive a certificate for attending or viewing on demand the 3 webinars of this series. There will also be a certificate for attending all of the BHA webinars that we present between now and September. We want to thank everyone for making time for this webinar in your busy schedules. We hope that it has been interesting and beneficial to you. Finally, we want to be sure to also thank everyone for the very important work that you're doing in helping to respond to humanitarian crises around the world. Again, thanks everyone, and goodbye.